Going to have an instruction course on endophthalmitis, prevention, treatment strategies, and the medical legal aspects. So, can I have my slides, please? Okay. So, we'll begin with the steps that we all should be taking for preventing this dreadful complication of endophthalmitis. And let's start with the basics. As you know, this is one of the most devastating complications following any intraocular surgery. And prompt diagnosis and treatment, although may be very important, but the most important strategy still remains is the prevention strategy. The endophthalmitis incidence varies from 0.05 to 1.5% in various literature, and the organisms that are more commonly associated with acute endophthalmitis are coagulase negative staph aureus, and streptococci, whereas the chronic endophthalmitis is usually caused by the Propionibacterium acnes or fungal species or coagulase negative staph and gram negative organisms also can cause chronic endophthalmitis. So prevention can be divided into four aspects. One is patient-related factors, doctors and staff-related factors, the surgical care, and the theater management. So coming to patient-related factors, obviously you have to take care of these risk factors like chronic blepharitis, conjunctivitis, dacryocystitis, and also the patients who have systemic risk factors such as diabetes and skin disease or immunocompromised patients. You should be more careful with these before operating these patients. One of the studies also has been very interestingly done to find out whether the OT staff are carriers of staph, and many a times this can be one of the important reasons for as a carrier for infection. And so patients who are staph carriers can probably be treated with nasal mupirocin or medicated soap for taking care of these carrier states. Coming to surgical care, the intraoperative complication is going to increase the risk of endophthalmitis almost 10 times. So these patients definitely require a close follow-up. For example, a patient who has a posterior capsular tear, it might be a good idea to take a small 10-0 prolines or a 10-0 silk or vicryl suture to ensure that the wound integrity is adequate. Of course, you must remember the gloves also may be harbinger of task-like infection, not exactly infection, but it can mimic infection. And therefore, we all must use starch powder-free gloves to ensure that there is no starch endophthalmitis. Coming to the most important point, and that is povidone iodine, the only established factor probably which has the highest significance in terms of prevention strategies is this drop, povidone iodine drop. But many a times what we tend to do is we start the surgery immediately after putting the drops, and so I feel that at least a contact time of 2 to 3 minutes must be allowed before you start your surgery. Povidone iodine can also be used in irrigating solution. A 0.25% can be prepared by diluting it and then continuously washing the ocular surface, especially for surgeries which take longer like vitrectomies. This can be one of the options you can think about. Another important factor is the care of the eyelashes. With the modern drapes that we use currently, this factor is definitely easily controllable, and also the surgical field can be definitely taken care of. You can also use some additional stickings to ensure that the eyelashes are not exposed. It is documented very much that the scleral incision is more stable and leads to chances of endophthalmitis which are much lesser as compared to the limbal or clear corneal incision. However, it is very important that you must have a clean incision, and therefore do not try to reuse the disposable blades, because the ragged incisions are equally culprit in causing the endophthalmitis due to the wound related issues. Coming to intraocular lenses, I think much has been discussed about whether hydrophilic is better or hyperonized is better. But I think talking about injectable versus non-injectable IOLs, it's the injectable lenses which should be probably preferred way out, because then you reduce the chances of handling related infection caused by the lens. Coming to another last and important part, nowadays most of the surgeries are done by phacosurgeons, are topical surgeries, and many of them do tend to advertise that it is going to be no injection, no eye patch surgery, but there is no harm for giving an eye patch for at least 2 to 4 hours. This controls the intraocular pressure, controls the integrity of the wound, and definitely reduces the chances of infection. But make sure that after the eye patch has been removed, the antibiotic drops should be started immediately so as to minimize the chances of infection. Coming to intracameral antibiotics, one of the surveys that we have recently conducted at the all India level, and the chances of infection after intracameral antibiotics have definitely reduced, and many of the surgeons believe that this infection control practice can reduce your chances of infection by nearly 70 to 80%. The adoption of intracameral antibiotics has increased in India from 40% previously 5 years ago to almost now 67 to 68% in the survey that we conducted recently. The reasons why many of the doctors do not still use intracameral antibiotics is the short life, then also the resistant organisms, endothelial toxicity, and task-like reactions that some of the doctors have encountered due to the intracameral antibiotics. Another interesting delivery system might be sodium hyaluronate hydrogel delivery system for carrying the antibiotic like a cefuroxime for management of endophthalmitis, but it still remains in a trial stage and hasn't really come up in a commercial preparation. In India, intracameral moxifloxacin is most commonly used antibiotic at the end of the surgery. And also you can soak intraocular lenses in antibiotics before injecting them inside in the eye. And bag and chamber flushing using intracameral moxifloxacin, another way of dealing with the preventive strategy is to dilute our moxifloxacin 0.3 ml and take 0.7 ml of BSS solution, so that makes it 30% solution as such, and then you can flush your bag with the diluted intracameral antibiotic. Coming to the theater environment, making sure that when the repair and maintenance work is going on, make sure that you do not carry on with any of the surgeries here. Also, cleaning of the operation theater is extremely important. In between the procedure and also at the end of the surgeries, you must make sure that the operation theater is cleaned like a terminal cleaning procedure. Laminar airflow system is very commonly used nowadays and definitely has a role in preventing endophthalmitis. However, the role in ophthalmic surgeries is not established because the duration of the surgery in our case is definitely less. But however, the duration of the surgery may be less, but the volume of surgery is definitely higher compared to the other subspecialties. So maybe there is a role to consider this laminar airflow system for your operation theater. Coming to cleaning of the equipments, and you must make sure that you can use an ultrasonic cleaner to ensure that the instruments are free of all the surgical material that may have got stuck onto the equipments. Also, the enzymatic cleaner that you may use can have a chance of creating toxicity like task-like syndrome. So make sure that you use the right concentration of these solutions. Sterilization can be done by any autoclave, making sure that your chemical and biological indicators are right. Currently, the most popular ones are the Class B autoclaves, and now the plasma sterilizers are also taking over. However, the cost is going to be extremely prohibitive when you use these kind of sterilizing equipments. Another interesting area and very detrimental area is going to be antibiotic resistance, and we will soon have to encounter all these issues. Currently, the most popular drug that we all use is fluoroquinolone, which probably will fall out of favor, and something like this might have to be considered for the future prophylaxis. Thank you. So with this, I end my talk, and I ask Dr. Vishal to please take over and start with his presentation. We'll have the question and answers at the end of the session. Thank you. And in case you have any questions, you may pass on the note to one of the coordinators so that he can hand it over to us, and we can have it during the panel discussion. Thank you.
Thank you, Dr. Aditya, for inviting me to his wonderful IC, and thank you again for letting me jump the queue. So I'll be discussing techniques and choices of intravitreal antibiotic injections in endophthalmitis, a very basic topic, but nonetheless a very important one. So we all know endophthalmitis is intraocular inflammation, whether sterile or whether infective, involving the vitreous cavity and the anterior chamber. And the standard of care currently involves prompt diagnosis, intravitreal injections, and in non-responsive cases, pars plana vitrectomy. So I'll not go into the details of endophthalmitis per se, but just a brief that it's classified into infectious and sterile. Infectious is exogenous and endogenous, as we all know. And the most common which we see is the acute post-op endophthalmitis caused by gram-positive Staph epidermis, Staph aureus, and gram-negative Pseudomonas, and delayed post-op with Trypanosbacterium acne. So early recognition, as I said before, is critical. High index of suspicion has to be maintained, and a complete ocular and medical history is essential. And a thorough ocular examination, along with ancillary testing like B scan, has to be done. Uh, before we start always with the empirical therapy, but we need a targeted therapy. So always take a aqueous tap and a vitreous tap from the anterior chamber and the vitreous cavity using a 27 gauge or a 30 gauge needle and send it to culture and gram staining and KOH mount. So coming to intravitreal antibiotics. So von Salman first demonstrated efficacy of these antibiotic injections for endophthalmitis in 1944. And in 1974, Payman actually used extensively the intravitreal antibiotics for endophthalmitis and determined the most important non-toxic dose for the most common antibiotics used. So drug delivery in the posterior segment of the eye is hampered by, we all know, blood-ocular barrier, and routine, intravenous injections and oral antibiotics have a poor bioavailability in the vitreous cavity. So intravitreal therapy in any form, whether it is anti-VEGFs or antibiotics, is a highly targeted modality. It maximizes drug delivery with minimum systemic complications, and it involves injecting drugs through the pars plana, which is a very safe procedure. It has a low learning curve. It's one of the most commonly performed procedures worldwide. The technique is made, this is for youngsters and the beginners, make the patient comfortable, explain the procedure in detail, always take a consent, a written and informed consent, along with the relatives. Scrub in, wash hands thoroughly, wear gloves. You don't need to scrub in totally, but that is also recommended. Use paracaine drops, avoid lignocaine as it's bacteriostatic. Apply a lid speculum and prepare the intravitreal fresh. Do not, use stored intravitreal injections. In a phakic eye, you can enter through the limbal route. Otherwise, after injecting, apply a cotton tip applicator to the injection site so that you can minimize the regurgitate of fluid. Examine the fundus and check the eye pressure and the optic disc digitally after the procedure. Do a paracentesis if you are injecting 2 drugs at a time. Any quadrant can be used. Most common, as we all know, as in all cases of intravitreal injections, the inferior-temporal quadrant is the most common. You generally inject around 3 mm in phakic eyes and 3.5 to 4 in phakic and pseudophakic eyes. So this is just a small clip of a video. You just flush the cul-de-sac with 5% povidone iodine, flush it properly. Tell the patient to look towards the other side where you're injecting, to have the gaze towards the other side, the opposite corner, mark with the caliper. Go inside with a 30 gauge needle, just put a cotton tip applicator at the injection site so that the drug does not get regurgitated in the subconjunctival space. So the dosage, it's based on how long the intraocular levels exceed the MIC of drug against the possible organism. The safety and efficacy of all these commonly used antibiotics have been extensively studied and documented in literature. Of course, there are special situations like a silicone oil filled eye, where you reduce the dosage to 1/2 to 1/4. And in vitrectomized eye, the dosage might be same, but the frequency of injections will be daily, as opposed to 48 hours or 72 hours in a non-vitrectomized eye. These are the most common antibiotics used: vancomycin and ceftazidime, which we all use in post-op endophthalmitis as the first line of therapy. You add 5 ml of distilled water, mix it well, take 0.1 of that mixture, dilute it with 0.9 ml of sterile water, mix it well, discard 0.9 and inject 0.1. The same procedure is followed in ceftazidime amikacin also. The duration and the interval between repeated injections varies from 48 to 72 hours. The special point in vancomycin is do not mix with other drugs because it precipitates. As you all must have noticed, it becomes a white precipitate if other drug is mixed with it. Sorry. So ceftazidime is basically a third generation cephalosporin with a broad spectrum activity against gram-positive bacteria and gram-negative bacteria, including Pseudomonas. And the second most common, which we use along with ceftazidime, is vancomycin, which is again a glycopeptide active against gram-positive, MRSA, and multi-drug resistant staph epidermidis. In case of penicillin allergy, you can use amikacin, but the macular toxicity and the retinal toxicity is a concern. Newer intravitreal antibiotics have come in. Colistin, although it is not new, it was launched 50 years before, but recent reports have deemed it very effective against resistant Pseudomonas infections. It acts by increasing the permeability of the cell membrane and could act synergistically with other antimicrobial agents. So most gram-negative microorganisms are susceptible, including multi-drug resistant Acinetobacter and Pseudomonas. Although in patients with kidney dysfunction, the dose has to be titrated. So most of these scenarios we have all seen: acute post-cataract surgery, chronic endophthalmitis, and intravitreal injection endophthalmitis. So these three categories, generally, you can give a trial of intravitreal antibiotics. Most commonly used drugs are again Vanco, Cefta, and you can combine it with dexamethasone also. But if in case there's a filtering bleb related endophthalmitis, a post traumatic or an endogenous bacterial endophthalmitis, they will not respond to intravitreal antibiotics, and in most of these cases surgery is required. I'll skip the antifungal part. Follow up and outcome. So how do you see the improvement in these cases? And when do you decide whether it is responding, you need a repeat injection, or you have to proceed for a surgery? The signs of improvement are close examination of the AC reaction, the hypopyon is reducing or not reducing, the pupillary membrane over the pupil is retracting. If it is retracting, is there a fundal glow? Is it causing a pupillary dilatation the next day? And the cornea is becoming clearer or more hazier by the day. The final outcome, as described in the EVS study, is the duration of infection, the presentation of the patient, and of course the virulence of the organism. So the management in EVS was described that you assess the visual acuity. If the vision is PL plus, you do early vitrectomy. If the vision is hand movements or better, you give a trial of intravitreal antibiotics. If it improves, you repeat it. If it does not improve, you go for a vitrectomy. That was around 3 decades back. But EVS study and subsequent guidelines continue to recommend PPV only under certain circumstances. Now we know that complete vitrectomy yields far better results after post-op endophthalmitis than those published in endophthalmitis vitrectomy study, because there is considerable better technical equipment, there are better illumination systems, and the optical systems, the wide angle systems are much better, and the surgery is much more safer. So there is a clear trend towards early and complete vitrectomy. Of course, if in your setup you don't have an in-house VR surgeon or a VR OR, of course you can give an intravitreal antibiotic, but promptly refer so the VR surgeon can attempt the surgery as soon as possible to give the best results. Thank you so much.
After the medical management per se, since we call injection therapy as medical therapy, we'll move on to the surgical management of endophthalmitis, and Dr. Anirudh Maiti will enlighten us on that aspect.
Very good afternoon. At the outset, I would like to thank Aditya for giving me this opportunity. Already, Dr. Vishal has given an overview, the intravitreal injection, the commonly used injections, and I'm going to speak on the surgical management of acute post-op endophthalmitis. So I will be showing few cases. First case was an acute post-operative endophthalmitis. As you can see in this case, there's a hypopyon, and this had an complicated surgery. It was operated for cataract, but the lens was not there. So there was a dropped lens as well. So first of all, we cleaned the anterior chamber. The hypopyon is cleaned. A day before, we had given the intravitreal as well. Now you can see dense exudates all over the retina, and the dropped IOL also we can see. What we need to do is a thorough vitrectomy, and we need to take out all the traction around the intraocular lens. Otherwise, while retrieving the IOL from the vitreous cavity, we might induce a retinal break. So once we have freed this IOL from all the exudates and the membranes, we take out the lens. Luckily, the cornea was better, so we could see what is there inside, and after retrieving, you can see the one haptic is already broken, so we retrieve the other part as well. And then the globe is closed, the main wound is closed, and we need a closed chamber to do our proper vitrectomy. Now we are left with a lot of exudates on the retina, as Dr. Vishal was mentioning, that nowadays with a better visibility, better viewing system, we can actually dissect quite a lot, and the target of the surgery is to clear as much as possible the exudates. Here I'm trying to do a base dissection as well. Obviously we need to be judicious in leaving, like sometimes the membranes are very adherent to the retina. It is not advisable to pull the entire membrane. When you see, it is not it is very sticky, and we might create an iatrogenic break, because creating a detachment in this kind of cases, the prognosis comes down. So as much as possible, we need to trim the base. And you can see the retina, we can now see the retina. It was entirely covered with the exudates, and then come out and give intravitreal injection. This patient did pretty well, and later on we had given a secondary IOL. This is after the surgery we are giving the intravitreal injection. Now second case, this is an acute onset, but it had a very delayed presentation. You can see almost there's a seclusion pupillary. So in this cases we have to retrieve we have to take out the IOL, otherwise we cannot proceed at all. So this is how we are actually taking out the IOL first. Once we have taken out, you see the entire globe is full of exudate, thick exudates. This patient didn't come in time, although it was an acute, but it was a delayed presentation. Now we are removing this thick exudates as much as possible. And the visibility was quite clear, so we were dissecting the membrane over the retina as well. The target is to remove as much as exudate possible, so that our intravitreal antibiotics work. So eventually the patient did pretty well. This is a the last case is a chronic endophthalmitis. I had already operated once, but it was like every time the exudates were coming and the patient was having symptoms. So this time what I planned is I will remove the IOL, because the bag was dirty. In spite of repeated intravitreal injection also, we could not get rid of the infection. So this is like in a chronic endophthalmitis, sometimes we need to take out the IOL along with the bag. So this was the plan. You can see on the retina there is the exudate lying, trying to shave off the vitreous base as well as much as possible. Sometimes with a sharp tip cannula we can actually take out um, uh, the balls of exudates which is lying on the retina. But we have to be very judicious, and we should not touch the retina, otherwise we will create a retinal detachment. So once we are through with this vitrectomy, or rather the re-vitrectomy, because we have already done in a primary vitrectomy, now we need to take out the lens. You can see the lens is the bag is dirty, so we have to remove it, and most likely this was responsible for this chronic endophthalmitis. The section was not that great. There was some iris prolapse, but somehow managed to take out the IOL and put a suture. And once we remove the IOL, we need to take out the bag complex because we know this is at fault. So if we clean up this area, we are going to save this eye. And eventually, actually, this patient did pretty well. So that's the end of the surgery, and then we give the intravitreal injection. Taking out the remnants of the bag. Now you see when we remove the bag complex, the visibility is much better. So the take home is early diagnosis and treatment with antimicrobial therapy are critical. Usually the diagnosis must be made under critical conditions. Treat with empirical therapy, usually vancomycin and ceftazidime. And obviously, as Vishal has mentioned, in the EVA study, perception of the light was the indication of doing a surgery, but nowadays we do it a much early and with a better prognosis. And whenever we give intravitreal, we see the response, and if it is not responding, we take a call of surgical management in the earliest. Thank you.
Thank you, Dr. Anirudh, for your elaborate presentation. Now, I would request Dr. Srinivas to discuss a few medico-legal aspects about this dreaded complication.
Good afternoon, everyone. Mike. Good afternoon, everyone. At the outset, I would like to thank Dr. Aditya Kelkar for giving me an opportunity to be in this interesting session. It's on medico-legal aspects of endophthalmitis is the topic given to me. So I'll see what best I can do and how justice I can do to this topic. Thank you, AIOS, for this and organizing a wonderful conference. So we all know that intraocular infection has always brought disrepute to the ophthalmologist. And this problem is not only rampant at the eye camps, but also in the hospitals where you can call 3-star, 5-star, or 7-star also, occurs in the best of the hands. Despite the best possible care, the mishaps cannot be avoided because an error in one link of the entire chain of treatment may sometimes result in a disaster. So a chain is only as strong as its weakest link. But if in the court of law, we have a misfortune of infection, then how to save ourselves? So first thing is maintenance of the proper records. Documentation of ocular examination includes pre, post-surgery, recording of the minute details. If require any ultrasounds or ECG, if the patient is not fit, histopathological reports are irrefutable proof of proper diagnosis and treatment and are extremely important for medico-legal aspects. So this was the case. The hospital and the doctor were guilty of deficiency in service as the case records were not produced before the court to refute the allegation of a lack of standard of care. Just because the case papers were not in a proper format, they lost this case. The doctor lost this case. So the machine reports, oxygen cylinders, ECG monitoring, pulse oximeters, anything, whatever we do has to be recorded, and whatever is relevant for that patient has to be done. And a general physician, his records are also extremely important, and all medicines or consumables should be of the standard quality. So let's look into this case, small case. Post-cataract surgery, both the patients develop endophthalmitis. Hospital was negligent as no proper sterilization was done in the OT by XXX hospital. I don't want to name this. This hospital was in Maharashtra. And that XXX hospital was resorting to shortcut methods in sterilizing and fumigating operating theaters. This was what the judgment. Well-equipped ophthalmic OT was not used by the hospital, and there were no autoclave records available in the register. The said doctor should have not selected the XXX hospital for conducting the surgeries on the complainants when he knew that there was no proper sterilization in the OT done by that hospital. So we know that nowadays many of the hospitals, they allow us to do the surgeries, the freelancing kind of things, but it has to be proper, because even though it is not your mistake, you are liable for that. Whenever we do in any other hospital and we perform it, we are liable for that. Negligence. The treatment or the standard of the care was not as per the standard textbooks and or accepted professional practice, and patients suffered loss or injury. These are the only wordings which are going to work in the court. Greatest malpractice risk associated with endophthalmitis is the analysis of claims show that a high index of liability arises from a delay in diagnosis or treatment, including a delay in referring the patient to the VR, thinking that, okay, it will slow down, there is small inflammation, there is iritis, it will slow down, it will come down, let us start from steroid. So these are the problems which can lead the doctor to go to the legal court if the patient complains about it. Now, how to beat this? If the surgery was complicated, took a long time, yes, definitely sometimes extensive instrumentation might be required. The higher index of suspicion of endophthalmitis has to happen in that. And what we tell at our institute Hubli is to do a SAVE, that is self-assessment of vision every day. Close one eyes and keep seeing at one distance. If they keep seeing it better and better, it is good. If it is worsening, then report back to the hospital immediately. You have to tell something to the patient, otherwise they will not be aware of it, especially when they come from the rural background. So educate your staff members who handle telephone calls about the risk and symptoms of endophthalmitis. Instruct them to schedule emergent appointments for that patient. Most of the times in the busy hospital, they try to take a routine appointment and they say the doctor is not available, come after 1 week. These are the most common problems which majority of the busy hospitals face. So err on the side of the patient safety when deciding to treat over the phone versus examining the patient. So document your decision-making process, obtain a thorough interval history and perform and document the clinical examination. In doubt, consult or refer the patients to the vitreoretinal specialist for further management. And of course, with proper documentation, make sure to document. So record all the findings, record and keep a copy with you. That is very, very important. And B-scan ultrasound if fundus cannot be seen at all is again very, very important point. And absolutely no telephonic treatment. The blind telephonic treatment is definitely sometimes a recipe for a disaster. Instead of telephonic, you can advise them to undergo the checkup at a nearest hospital wherever they are. So patients on treatment for endophthalmitis definitely should be evaluated. You all know that. And any case of pain, redness, decreased vision, then the patient has to be said to go to the nearest doctor. And measures to be taken to reduce the liability is proper informed consent. I think that there is no way we can get out with that. And emphasize the risk, especially if the patient has diabetes or on immunosuppression and complications including infection that can happen in the best of the hands. So have a prudent follow-up, diligently follow up all the patients who miss or cancel the appointment, especially the post-op patients, and contact them immediately if any pain or loss in the vision. Anterior-segment fundus photography should be taken in the post-op if possible. Now coming to the interesting part is about the camps. The camp should not be used as an unsupervised training ground for postgraduates. There should be a pathologist who should examine urine, blood sugar and everything. A physician for the general medical checkup is a must, and all medicines consumables to be used of standard quality. Why I am saying this? Look at this. The original jurisdiction written petition, Supreme Court says that, okay, Lions Club Pottery Town in Khajuria arranged and opened an eye camp at Khurja after obtaining necessary permission from the CMO. In this connection, the club invited Dr. X and the team of doctors to do the surgical job. So I am deliberately not naming the doctors here, but these are all the well-proven one, and on the records I have taken this. The club published the propaganda literature with attractive slogans selling that get operated and go home. No restriction on food, no bed rest, no stitches to be removed. So sometimes we trivialize our own surgeries. Will any neurosurgeon say that, okay, we'll do a small burr hole, we'll remove the blood and you can go home? Will any cardiologist say that a small stent is required in your heart? We'll just put it and you can start walking. We ourselves are trivializing our own surgeries. We say that छोटा सा फेको है, get a phaco done and go and play golf. छोटा सा है, आपको ये नहीं, you can go to the, see, we trivialize because of increasing package rate. Sometimes some ophthalmologists, we try to trivialize our own thing. So 108 patients were operated, 84 developed endophthalmitis. The Supreme Court let down the guidelines after this incident. The fault was in the saline bottle procured by the government authorities, and the government was asked to pay for the compensation. So the doctor was, fortunately, he was saved, because if you don't know, then you have to find out where is the culprit, because sometimes you are not in the faulty chain. Sometimes the drugs or usables might be faulty. So you have to find out what is the faulty and you have to prove it. Otherwise, the blame comes on the doctor. If it is any products which we procure, then it goes to the vendor, whoever gives you that. Dr. X presented. So this was another interesting. Cataract surgery was performed, 66 patients at a reputed hospital in South India on that night. Most of the patients experienced excruciating pain, and 61 of them lost their vision. 5 partially lost the vision. So the Chief Judicial Magistrate Court, which heard the case, convicted Dr. X of XXX Hospital, Chief Medical Officer, Chief Administrative Officer under Section 338 for culpable negligence and endangering the personal liberty of the patients and voluntarily hurting them. So the court also ordered the payment of a compensation to all the victims ranging up to 5 lakhs. And since the victims have already been paid, so they come under, the compensation was fixed based on the Workmen's Compensation Act. So I'll not go into the details of it, just in 1 minute I'll finish it off. Whenever the complaint is received against a doctor by a hospital, by the consumer forum or by the criminal court, nowadays all the cases are being shifted to, most of the cases are being shifted to the consumer court. And IMA actually lost the case when they fought it that the medical service, it's not considered as a service. It's the noblest kind of profession what we are doing, and it should not be considered as a service and treated as a service like how you have the banking service, how you have these kind of services. But unfortunately, the IMA failed in that case, and the cases now can go to the consumer court, and from the consumer court, again, it takes a long legal battle. So now it is totally at the discretion of the court and not a hard and the fast guideline. So again, the death caused by the penalty, Section 304A IPC can be used, but for our safety, act not intended to cause death done by the consent in the good faith for person's benefit come under Section 88 of IPC. Act done in good faith for the benefit of person without consent in emergency cases, it is considered as Section 92 of IPC. And lastly, I would like to say, it's not merely on the formulation of the theoretical standard, but really on the professional commitment with which these are implemented. So please document. An ounce of prevention is better than a pound of cure. Thank you very much for the patient listening.
Thank you, Dr. Srinivas, your excellent talk and clear thoughts on the medico-legal aspect. We also welcome Dr. Namrata Madam for her presentation, and in the meantime, while she loads her presentation, we have a comment from Dr. Manish.
So, this is a comment from personal experience. The thing, when you are referring a patient, actually there are a few things that we need to understand when we are referring the patient. If there is a patient develops endophthalmitis, usually there is a reaction, mental reaction from operating surgeon that they pay the patient money back, and they want a VR surgeon to intervene free of cost. These two are common things that happen, and one case that in my professional life as VR surgeon that I have to face is where I was told to not charge the patient. The surgeon had paid the patient money back. That patient takes as admission of guilt, and you are more likely to get sued. So make sure that none of such a thing is not done. Fact one. The second thing is, if the case does go in court of law, make sure that the case is sent to the medical board, because the lawyers involved in the procedure do not necessarily understand, and judges do not necessarily understand. as there is a aggrieved party who has lost the eye, they have advantage over you as a surgeon for when it comes to getting the benefit of doubt. So the the fact that there is negligence or not comes later. But and many times the case where I'm facing, we had to insist to the consumer board to take the case to the medical board. It was not referred as a natural flow. So make sure that your case goes to medical board. It is consisted by local medical college dean. There is a physician. There is a head of department of ophthalmology. If your documentation is correct, if everything is done without negligence, they are the ones who will save you. And if there is a this thing coming from them, as there is no negligence, you are better saved. That doesn't mean that you will get verdict in your favor, but you are much better saved in that case. So these are 2 points that I had to add to this thing.
So thank you, and I do apologize for the delay because I was in some other session. I would be talking to you, I'm sure you would have discussed everything about endophthalmitis, but I would be talking to you steps in preserving corneal health in endophthalmitis. And cornea can be involved not only in endophthalmitis but also TAS. Having said this, even after doing a corneal graft, one can get keratitis and endophthalmitis. It is important to differentiate TAS from endophthalmitis, and one very important sign therein would be severe limbus to limbus involvement, which occurs in TAS, and there is corneal edema, unlike in endophthalmitis, where it may be just mild. Histologically, if you see, then TAS specimens do have shown various changes like decreased endothelial cell density, structurally disturbed collagen bonds, epithelial cell layer changes, and stromal edema, fibrinous membrane over the Descemet's membrane with several layers of elongated fibroblasts, etc. And there can be complications also because of TAS, such as endothelial cell loss, epithelial downgrowth, and secondary glaucoma, raised intraocular pressure, which can again cause corneal edema. The management of such cases remains essentially topical steroids, and increasing severity, gel steroids can be given, topical NSAIDs, IOP management, and refractory cases, people have even tried recombinant tissue plasminogen. Now, resolution of TAS with medical management can occur, such as in this case, when over a period of time the cornea does clear up. Surgically, it would depend on the severity and etiology, and it has been shown that 30% of the cases would require some kind of surgical intervention, endothelial decompensation if it is there, and not getting treated by the medical management for 6 weeks. You may have to do an endothelial keratoplasty or full thickness keratoplasty, and generally one has to wait for 3 to 6 months for optimal visual results. After having TAS, when you do endothelial keratoplasty, if you don't wait, then there's every chance that even in the secondary surgery that you do, there may be TAS and there may be increased reaction. So it is imperative to wait for at least 6 months after TAS if you have to do endothelial keratoplasty. And refractory glaucoma cases may also require filtering surgery. This is the publication that we've done of DSEC in TAS, and visual acuities were good. They do recover well. Of course, prevention is more important in these cases, just like in endophthalmitis, taking every care that these don't occur. As far as endophthalmitis is concerned, there may be cases where cornea is not involved at all, and there may be cases where there are corneal infiltrates present, or this generally is related to the wound abnormalities which may be there after cataract surgery. Corneal incision has classically been implicated, especially in the earlier studies where it was believed that clear corneal incision has greater incidence of TAS as compared to scleral incision, and ECC has more endophthalmitis as compared to phaco, and clear corneal incision has more endophthalmitis as compared to the scleral tunnel infections. Preoperatively, it is very important to see that the ocular surface is optimally managed, especially in patients who have atopic disease, or patients with rosacea, mebomitis, blepharitis, and even systemic conditions like diabetes may cause delayed in wound healing, especially the wounds of the cataract surgery. As far as the corneal incision is concerned, like I said, size of incision is important. Location of incision is also important, and it is imperative that there is no wound leak after the surgery has been done intraocularly, and one should always check for the water tightness of the incision. And wound management is vital because you cannot afford to have hypotony and you can't afford to have wounds which leak. Now, the corneal involvement can be in the form of corneal infiltrates, corneal edema, corneal opacities, and endothelium precipitates on the cornea. This is a case of corneal tunnel infection, tunnel infection, which is actually going onto the cornea with endophthalmitis after SICS. And then you can have endophthalmitis with complete involvement also of the cornea, as seen on the picture on the right. Apart from this, there can be keratotic precipitates as well. Now, it is important that in these cases of endophthalmitis, if vitrectomy is required, it is done early, because if it is done later, then the corneal changes may ensue, and that may impede the visualization, and it may vitrectomy or surgery may become difficult. With the edematous cornea, like I said, keratotic precipitates on the corneal endothelium may be there, and delayed onset manifestations of endophthalmitis also include band keratopathy and corneal opacification. Now, corneal edema can be epithelial edema or can be because of the infection itself, and sometimes it just gets cleared by the topical steroids and by anti-glaucoma medications. And there has been a meta-analysis which has very clearly shown that CCI or clear corneal incision is a risk factor, where increased endophthalmitis rates of 0.189% were seen as compared to rates of 0.074%, which is seen in the scleral tunnel incisions. And in the ESCR study, the clear corneal incision was found to have 5.8 times more likely to contract endophthalmitis than patients undergoing scleral tunnel technique. Now, apart from this, the corneal infiltrates can be there, and again, they can be localized or they can be diffuse, and these have to be treated with topical antibiotics, as well as you may require even intrastromal or intracameral drugs, especially if the infection is due to fungal organism. And at times, the situation gets so worse that you may require a temporary keratoprosthesis plus vitrectomy, core vitrectomy for the infection, or complete vitrectomy, as I think as they do nowadays, along with a penetrating keratoplasty. And this is just to show vitrectomy, which is done through the hazy cornea in these cases of endophthalmitis. And sometimes the situation can be like this, where in a graft you have corneal infiltrates as well as endophthalmitis which is present. So this is in fact a case of keratoprosthesis where endophthalmitis was there, and in this case the vitrectomy was done, and subsequently the keratoprosthesis was replaced with the help of a penetrating keratoplasty, which was a therapeutic graft. So suffice it to say that cornea may be involved, may not be involved, or may be involved only subtly, or there may be frank infiltrates which may be present with keratitis, or it may be a full-blown keratitis with endophthalmitis, and all these spectrum of corneal involvement would require separate lines of management, which I have discussed, and one needs to be sensitized to that. Thank you very much for your kind attention.
Thank you, ma'am. A couple of questions for you. Is one of the things is many a times when the view is not clear, when the retina surgeon wants to do a vitrectomy, he cleans up the cornea by scraping the corneal epithelium. How quickly would you recommend starting the topical steroids in these cases who are already infected? Is there an additional risk that the infection might spread onto the cornea?
Epithelial debridement would definitely be an additional risk factor for infection, and so topical steroids I would perhaps start on day 3 when at least epithelium starts to come up. Also in these cases you can also put glycerine on the surface of the cornea, so that itself will cause some clearing of the cornea and will allow you to do a vitrectomy.
How about putting a bandage contact lens in such situations? Is because contact lens itself per se might be considered as a potential source of infection.
From the cornea point of view, if you ask me, I would rather not put bandage contact lens but do a lateral tarsography, in these cases because bandage contact lens is also a nidus for infection.
Right. Thank you very much, ma'am.
There are some cases we see that there is a ring infiltrate which starts developing. Typically, when there is a scleral involvement is also there, it tends to spread. Is there any, can that get us a idea about what kind of organism we are looking at, what kind of organisms cause these kind of presentation? That might give us.
So ring infiltrates classically would occur in cases of acanthamoeba keratitis. But having said this, there are series where ring infiltrates are not associated with organisms, and they have been associated with all sorts of organisms. So I think we cannot definitely say that if the ring infiltrate is there, then it is A type of organism or B. That has to be microbiologically proven. And I'm sure you would have, when you give intravitreals, would have a vitreous tap. So that would be a more definitive way of knowing which organism it is.
Thank you, ma'am. Next, we have Dr. Manish, who is going to talk about traumatic endophthalmitis.
Good afternoon, everybody. Thank you. At the outset, I would like to thank Dr. Aditya for inviting me as a speaker to this instruction course. I'll be speaking on traumatic endophthalmitis. The slides are not moving. Okay, so looking at the post-traumatic infectious endophthalmitis is uncommon but very severe complication of ocular trauma, and reported incidence in patients who received prophylaxis range from 0.5% to 18.5%. However, in patients who have not received, the incidence has been reported from 3 to 11% in absence of IOFB, but as high as 48.5% in patients with IOFB. These are the risk factors, that is retained intraocular foreign body, rupture of crystalline lens, delayed primary repair, more posterior injury like posterior scleral tears, ocular tissue prolapse, rural setting, older patients, males, larger wound size, and placement of IOL, that is patient who has undergone cataract surgery in the past. The signs and symptoms can vary, unlike the post-operative endophthalmitis, which has more predictable course. The post-traumatic endophthalmitis can have signs and symptoms which are varying. The one typical symptom is pain, which is way out of proportion to the signs which are seen on examination. The patient may have very severe photophobia, visual acuity is way more reduced than what you would expect, lid edema, chemosis, and obviously purulent exudation. If it is seen from site of injury, that is a sign. There, along with the various signs that we have already seen in earlier presentations, we can have presence of retinitis or periphlebitis alone as early sign. So this was a patient where you can see in the at the time of presentation, though there was a very large foreign body, the vitreous cavity was clear and there was no periphlebitis. While when I took the patient for surgery after 10 hours after doing the initial preparation, we could see that there was periphlebitis and this frosted branch angiitis appearance had developed already, and the vitreous sample did show organism. So this was the only sign. Otherwise, vitreous cavity was quite clear in this patient. Investigations. CT scan should be done in patients of trauma where you are suspecting intraocular foreign body. Make sure you ask the axial and coronal scans and look for the take thin cuts, 1 millimeter to 2 millimeters, because you can see the foreign body. Very small foreign bodies, like in the foreign body which is seen here. This was seen in only these two sections which are seen on the picture. So the rest of there was nothing seen. So it was a very anterior foreign body, so nothing was seen on B scan. Clinically, it was not seen. Only CT scan gave us a picture, and that was also because very thin cuts, 1 millimeter sections were taken. So make sure you ask for thin sections if you can't see the foreign body. B scan ultrasound has to be done gently without putting pressure if the eyeball is open. It is non-metallic IOFB, severity of vitritis, status of PVD and attached and detached status of retina is what you're looking at when you do B-scan ultrasound. Investigations you have to do is take culture from wound site, take anterior chamber and posterior chamber tap. While taking posterior vitreous tap, it is better to use cutter rather than just do suction. We have to ask for various bacterial and fungal staining as well as the culture and sensitivity. In patients where there is after doing everything, about 70% of the cultures do not grow any organism, and you are probably treating the patient on empirical and clinical basis. PCR can be considered if the case is very fulminant and or non-responsive to the treatment. Causative organisms, unlike post-op endophthalmitis, the organisms can be very, I mean, they may not be always predictable. Bacillus cereus is found to be in very high number of patients involvement. So Clostridia, Streptococcus, these are very virulent organisms and have poor visual prognosis. In traumatic cases, if there is a vegetative injury, foreign body expected, then we have to suspect fungal organism has to be suspected, and accordingly the cultures and sensitivity has to be done. Factors which are give visual prognosis is these are typically the factors, but usually the visual prognosis can be very poor. The progression of the disease can be very rapid despite prompt and aggressive intervention. So this has to be explained clearly to the patient at the beginning of the treatment, so as to it you are again medico-legally safe, and sometimes what happens is that when patient presents at the time of injury, when you are doing primary wound repair, there is no obvious signs of endophthalmitis, but they develop later and patient blames it on your surgery. So make sure that you do prime the patient that there is a possibility of traumatic endophthalmitis even after best of your efforts. Medical treatment has been discussed in great detail in the earlier talks, as well as the surgical management. Only thing is that we have to be much more aggressive in doing surgical treatment in these patients, especially when there is a intraocular foreign body is present. The vitrectomy has to be complete even if there is no foreign body, and the goal of treatment is like any other case to debride the infected vitreous and give intravitreal antibiotics, but also along with that IOFB removal has to be done. So this was a 35-year-old male patient who had trauma while working, and there were initially primary wound repair was done at the site of the entry of foreign body. There was endophthalmitis was already present, so initially the cannulae were inserted and anterior vitrectomy was done. Then the paracentesis was done and anterior chamber clearance was done, and it was sent for lab test. Complete vitrectomy is done. Initially core vitrectomy is done, and then the PVD induction has been done. So PVD is induced, and complete vitrectomy is done in this patient. So the foreign body was present in supranasal quadrant. So there was blood clot which was present on top of the foreign body. Vitrectomy is done to release the foreign body from the vitreous adhesions. Then the cantilever was inserted and supranasal sclerotomy was enlarged. Magnet was used to pick up the foreign body and remove it from the eyeball. As the foreign body was larger, I had to enlarge the sclerotomy and then remove it. Once that was done, meticulous suturing of the sclerotomy is done, and meticulous endolaser was done around the site of impaction of the foreign body. There is gas injection done at the end, and cannulae were removed after closure of the wound. So these are our publications in patients with trauma. The first publication was where the child had traumatic endophthalmitis with bow and arrow injury following when the Ramayana serial was started in the at the time of lockdown, when the Ramayana was shown, the bow and arrow injuries had gone up, and this was a child who presented with traumatic endophthalmitis following that. This was published in IGO. Thank you all for your kind attention.
Manish, can you tell us more about your forceps, the intraocular forceps for foreign body? Because many patients who have traumatic endophthalmitis might have a concurrent intraocular foreign body. And
Yes.
Dr. Manish has designed a very interesting forceps for especially tackling the various sizes of the foreign bodies. Please
Yeah,
explain
so
more about it.
the forceps that I have designed is called as the claw forceps. It has 4 prongs which can be retracted into the holding cylinder, and we can insert the enlarge the sclerotomy to 17 gauge and then insert. And as the forceps goes inside, we can open the prongs, which can go open as much as up to 12 millimeters, and very large. It's basically designed for very large and non-magnetic foreign bodies, which are very challenging to remove because these are heavy. They cannot be lifted with standard forceps. We cannot float them with LPFC, and we need something to pick these foreign bodies up before removing it from the eye. So that was a forceps which has been designed. It is quite well received by vitreoretina community, and it has also I have had the honor of winning the trauma award at AIOS which took place in 2018 at Coimbatore, but that is and also at our state level also. But that is a device which can be used in difficult foreign bodies. Thank you.
Thank you, Dr. Manish. Now we have Dr. Subhendu Boral. He is going to discuss about management of fungal endophthalmitis, one of the again dreaded complications that we have. And then if there is time, we might have some panel discussion and some clinical scenarios to discuss. I think it's on this side. So, Dr. Manish, any specific and intravitreal injections that you prefer in trauma cases, like routine vancomycin may not be sufficient?
So initially, obviously, I do not give. Initially, we start with vancomycin and photom or amikacin. However, intravenous antibiotics are also given. They are found to be effective much more than post-operative endophthalmitis. The linezolid is what I usually start with in intravenously also. And if there is a gram-negative infection is suspected, as Dr. Vishal had shown, I add colistin along with piperacillin tazobactam. You essentially have to go to higher spectrum of antibiotics in these patients. Colistin acts by, we have to add it with some other gram-negative acting antibiotic as well, because it breaks down the bacterial cell walls and increases the effectivity of other antibiotics as well.
And why do you think that it works best with intravenous antibiotics, especially the trauma cases? How do they differ from post-op?
Well, there are studies which are carried out which have shown that probably the severity of infection is much more severe, and that seems to work better than post-op patients.
Right. So with that, Dr. Subhendu, please take over.
Good afternoon, everybody. Thank you, Dr. Aditya, for inviting me in your course. So whenever you see postoperatively this kind of picture, mild corneal edema, AC cells flares, with or without hypopyon, poor glow, and the vitreous membranes and mild grade of vitreitis, and it is going off on by applying this topical or systemic steroid. Think about the fungal endophthalmitis. So fungal endophthalmitis is actually caused by the intraocular fungi infection originating either from exogenously from penetrating trauma or by surgeries, or endogenously from the hematogenous spread. It is highly variable in clinical picture. A post-operative fungal endophthalmitis, although it is rare, it can occur due to the Aspergillus or Candida species. It can present as subacute postoperative endophthalmitis or chronic postoperative endophthalmitis, just like other picture, but not that fulminant with or without hypopyon, or with, I am coming to the other clinical pictures. It's another mode of endophthalmitis, fungal endophthalmitis, post-traumatic. Although bacteria are the commonest cause, but Aspergillus is the most prevalent fungal cause of post-traumatic endophthalmitis. And the continuous spread of the fungal keratitis, it is the rarest of the fungal endophthalmitis. So endogenous endophthalmitis is another mode of presentation of this fungal endophthalmitis. This infection is secondary to the hematogenous spread from a distant infective source within the body. It actually occurs in 5 to 10% of the all endophthalmitis cases. When actually they are in the bloodstream, it affects the choroid, because choroid is a very vascular structure, crosses the blood-retinal barrier, infect the choroid, then followed by subretinal space and the retina, and present as focal chorioretinitis or focal retinitis. So that is the one of the variety of endogenous endophthalmitis. One of the 4 types of that is anterior focal, anterior diffuse, posterior focal, posterior diffuse, and the pan-uveitis like picture. So the causative organism may be bacteria as well as fungi. Fungi causing the endogenous endophthalmitis principally it is their Candida albicans and Aspergillus, and rarely yeast. So these factors, either immunosuppression or any procedure that increase the risk of blood-borne infection, that cause that infection. So in immunosuppressive diseases like diabetes, HIV infection, all of the cancer, renal failure, all are like using a long-term use of the broad-spectrum antibiotics, steroids, immunosuppressive drugs. They are risk factors, and the major surgeries either by the intra-abdominal surgeries or hyper-interventional IV catheter use, or per se systemic immunosuppression is not influencing the development of intraocular candidiasis, because it does not increase the access of candida into the bloodstream. So decreased vision, pain, out of proportion, edema, corneal edema, corneal ring infiltrate, or keratitis, anterior chamber inflammation, hypopyon, all these are fungal ball over the iris, and vitreitis or frank purulence is the common clinical features for a case of this fungal endophthalmitis. And the mode of diagnosis, like if diagnostic tools are most on the ultrasonography, you have to do it whenever you see there is loss of glow, like the very poor glow, or you can hardly see the fundus. So they are actually non-specific, but sometimes you can see the membranous picture in the inside the vitreous cavity. And the culture of the intraocular fluid is another mode of diagnosis, either from the anterior chamber or the vitreous tab. You can do the blood culture for a complete workup of the systemic infection. PCR is, you can take the vitreous biopsy. I'll show the video how to take the vitreous biopsy. So basic steps, and you can send it for the laboratory use of like using the KOH staining, as well as the culture, as well as the PCR use of PCR to diagnose the what is the to detect the fungal DNA if possible. And recently they have measured the levels of intraocular fluid beta D glucan, which is actually described by Chen et al. In 2020 as having the close association with the fungal endophthalmitis and being more sensitive than the culture methods, as it is limited by the inability of to confirm the specific diagnosis. So management depends on the actually it's the fungal and systemic antifungal therapy, either fluconazole or voriconazole for candida. Intravitreal therapy for fungal endophthalmitis, either intravitreal amphotericin B or voriconazole. So both are good, equally good, but voriconazole has a lower risk of retinal toxicity. This is the drug intravitreal preparation. I'm not going into the details, but just amphotericin is covering the candida aspergillus, and voriconazole also aspergillosis, invasive aspergillosis is better than amphotericin B, and for candida it is as effective as amphotericin B. So the advantages of vitrectomy are as of routine bacterial cases, but additionally it can decrease the risk of further retinal detachment. So this is the another thing. But retrospective study, one small retrospective study has been done where 44 eyes with endogenous candida endophthalmitis was actually at early vitrectomy didn't help much to prevent further profound vision loss. So how to take vitreous biopsy? This is the video I'm showing. That is before starting your vitrectomy, you should take the vitreous culture by cutting the aspiration tube with the 1 ml tuberculin syringe and using visualizing the vitreous membranes with the help of your endoilluminator. Start the cutter with the cutting mode only without making the infusion on, and take the sufficient fluid from the vitreous cavity to send it for the KOH staining, for the culture, as well as the PCR reaction, so that you can reach to the proper diagnosis, whether it is bacterial or fungal. and that will help in further management. So I'm coming to the one practical cases where post-operative chronic endophthalmitis, ultimately patient came and the diagnosis was aspergillosis. So vitreous biopsy showed aspergillus in the vitreous culture, vitreous biopsy material shows the aspergillus species, and you can see the basic steps to manage the endophthalmitis case. You should remove all the media opacity. That is the most important part. That is, you should remove all kind of media opacities, like from the corneal edema. You should remove the corneal epithelium, followed by anterior chamber membranes. All the membranes should be removed with the help of either this Sinsky or the Dumble cannula. You can see I'm just trying to remove the membranes were very tenacious. So you can always use cutter to remove these membranes, basically to visualize the further now you can see I can visualize the anterior chamber, that posterior chamber lens, and using this cutter I am removing all the pupillary membranes, and finally you can see it is almost clear, but you can see the tip of the cannula. After checking the infusion cannula again, then I'm starting my vitrectomy part. Then after doing initial anterior vitrectomy, you can see the vitreous exudates and the fungal cotton ball exudates overlaying the retina as well, and throughout the vitreous cavity. You can see all the membranes. These are the real time. You can see the characteristic membrane of any kind of the fungal endophthalmitis. Wherever you can see the membranes always have it should be there's a good high suspicion of fungal cause. And after removal of all the membranes, you should remove all the fungal balls overlaying the retina, and sometimes it is it's difficult to do the posterior vitreous detachment, but still you can use the cutter to remove all the IPVT part, and just remaining part of over the length disc, you can lift it as such, and using either section of the cutter or using the proportional reflux mode of the cutter, you can remove all the vitreous cotton balls, and finally inject the intravitreal antibiotics as well as the antifungal drugs. Sometimes what happens when you are injecting both vancomycin and voriconazole, they can form precipitate formation. So these are not hypopyon postoperatively. If you see, you can detect it on the table also. So always keep in mind that the other difference in diagnosis, like non-infectious uveitis and infectious chorioretinitis, like bacterial endophthalmitis, viral endophthalmitis, and toxoplasma chorioretinitis. Also try to rule out the malignancy like intraocular lymphoma and retinoblastoma in children. Always have some mimicking picture with the fungal endophthalmitis. Thank you.
Thank you, Dr. Boral, for your excellent talk. Would you be hesitant in adding steroids when you have the fungal endophthalmitis in the first intravitreal injection encounter that you have? Suppose patient has come post-operatively to you, you suspect fungal endoph. How do you want to give intravitreal antifungals with steroids or without steroids?
No, we are not adding steroid when I have a strong suspicion of fungal endophthalmitis. But later on, if sometimes what happens, that is also reverse kind of situations may happen, and when you do not know whether you are suspected with the bacterial endophthalmitis, you have given steroid, and ultimately culture came positive or KVH stain came positive. So after 1 or 2 days, I am just stopping this in the steroid drops. But when you suspect the fungal endophthalmitis, you should not start this thing. A non-steroid anti-inflammatory drug should be or you can use the cyclosporine.
Yeah. And your drug of choice is intravitreal endophthalmitis fungal drug of antifungal.
I am just, that is the empirical dose of that is vancomycin, voriconazole or amphotericin, whichever is available, and cefuroxime or ceftazidime. Yes.
So mainly it's about voriconazole or amphotericin B between the two.
Amikacin in post-traumatic endophthalmitis.
Right. Thank you. Thank you, audience, and thank you all of you for your patience. With that, we hand over the mic to the next speakers and the instruction course. Thank you.